This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thanks very much, Liz. I've been asked, yes, as Liz said, to talk about whether our involvement in this stage, because we were set up initially to save people's lives, but we've gradually moved into this area, whether we like it or not. Is it? Sorry, is it the arrow or the... Oh. Now I've wrecked the whole thing. 1 minute. No. Help. Is it the arrow? Okay, sorry. So, there's a tsunami, all right, the care of the elderly frail at the end of life. I like this word frail, and I think that more and more of us are using it. And there's about 30 different ways of measuring it, but common to all of the ways of measuring it is gait speed. And when I found out that gait speed is correlated with how long you've got to live, I used to try and spot people of about my age and see if I could walk faster than them, in the belief that if I could walk faster, then I'd be living longer. And until I got attacked by orthopaedic surgeons about 2 months ago, and my gait speed slowed down, and I'm thinking I've got a very limited outlook from here on. So the background, how did all this happen? Well, most people would like to die at home. 70% of Australians, 70% of Americans, 70% of Europeans would like to die at home. And yet only 14% of Australians die at home. So there's increasingly aggressive treatment of the elderly frail. We all know that, and we've heard from various speakers this morning that this is what happens. And we also know that hospitals are not a good place to die. It's a great place if you need your coronary artery stented or an operation or things like that, but we're very, very bad and even cruel at the way we manage end-of-life care. And we also know that this is costing us a huge amount of money, increasing amount of money in an increasingly unsustainable health budget. So this is really interesting. Nobody really wants it this way. Patients don't want it. Carers don't want it. We don't want it. Doctors, nurses don't want it. Society don't want it. 70% want to die at home. Only 14% die at home. So how the heck did all this happen? Well, I think it goes back to if you got sick, say, in the 1950s, then the GP came that day or the day after or whatever with a very limited ways of treating you at that stage, whereas now if you get sick at home, whether you're old, about to die, or young, or get hit by a car, the first instinct is to phone an ambulance. And then you're on this conveyor belt. The ambulance takes you to the emergency department. The emergency department have 4-hour rules and things like that. They're into packaging. They're not into making many, many phone calls about trying to find out what you want and how to give you that treatment. So then you end up in the hospital bed and you're at the end of life, and then, as you know, we all get calls about, you know, Ken, I've got this patient on the ward, I've just spoken to the relatives and they want everything done, and you think, don't ask that question like that. But anyway, so you go down and try to sort it all out. And so there's been this medicalisation of the dying process, a bit like the birthing process in the 1950s and 60s, where it was totally medicalised. Women were brought in, put up in stirrups, baby taken away, baby put in with other babies, father not let to look at them, and then 3 days later you were sent home. It's a bit like that. There was no choice. And I think that's what's happened in our society at the moment. So many of our speakers have talked about this. We set this system up, this medical emergency team, rapid response team, to identify sick people early so that we could prevent them dying and having cardiac arrest. None of us anticipated that, of course, you can't die without hitting a MET criteria. It's impossible. They're going to get you at some point or the other, even if it's a cardiac arrest. So we were picking up people that were dying. And I believe, and this has been talked about by many people this morning, one of the most important papers in the last 50 years has been the one published by Darryl Jones, one of the organisers or the chief organiser of this conference, a multinational study, Australia, Sweden, Canada, which found this really interesting and very, very important finding, that 1/3 of all our calls are for end-of-life care. Now, you think this through. This is absolutely crucial, because it means that patients at the end of life are not recognised by the current system. Just like seriously ill people weren't recognised before, now dying people aren't recognised. And I think that's extremely important. So patients at the end of life are admitted to the hospital under the delusion that they're there to be treated. Maybe not to be cured, but to be made better. And I think that our colleagues are also under that delusion. Otherwise they wouldn't be admitting people at the end of life. They believe these patients are there to be made better. And nobody has had an honest discussion with the relatives and the patients, because they don't know that they're dying. So our colleagues either cannot diagnose dying, they don't know how to deal with this whole potentially unpleasant business, or maybe they don't want to deal with it. Nobody's done much research into why exactly people at the end of life aren't recognised. So as we've heard, the MET team has become the surrogate dying team. And one of the problems, and I guess one of the things over the next few years, is that we're recognising them, but what do we do about it? If we recognise the sick people that we can make better, we know what to do. A, B, C, etc. But we're not necessarily the right ones to deal with once we recognise them. I've got no problems with the fact that we're recognising them. Well, I have as well. I've got problems that it's left to us, but that's just the way it is. But now we need to link it to a different rapid response, a different system, a different effort arm, if you like. So at the moment, whether we like it or not, we're the only ones who are recognising it. And I used to, and I still do, get very frustrated with my colleagues. And then I suddenly thought that we're probably the ones that diagnose, in many ways dying anyway, in the intensive care unit, in that we're the ones that say, we have nothing more to offer. And currently surgeons and physicians see that the next step is intensive care. And that's why it's so frustrating with us. They refer them to us because they believe we have something more to offer. And so I think in some ways this has been landed in our lap, to be the ones that say we have nothing more to offer. So to put this in perspective, there are about 45,000 rapid response calls in New South Wales every year. So 15,000 of those calls are for people that are dying. That means 50 people per day in New South Wales are dying unrecognised until the last minute when a rapid response team turns up. So is it good or bad? Well, it's certainly bad because we have stretched ICU resources anyway, so to be asked to do all this extra work is not good. And it's not good for the frustration levels of people in the rapid response team, and I'm sure everyone in this room faces this frustration all the time. But if you listen to Michael DeVita's talk this morning, it's inconvenience versus the patient. Sometimes it's more than inconvenience. It actually stretches our resources beyond what they're capable of doing. So that's bad. Is it good? Well, it's good in some ways because it is drawing society's attention to arguably one of the most important areas of health, that people come to the end of life, but medicine does not know currently how to recognise it. It's good because we can't hide from the next step, whatever it is. We're recognising it. We've got data to say that we're recognising it. What is the next step? We can't hide from it and say it's not our problem. We can't do that anymore. It's good because it broadens the concept of intensive care medicine. Just like we were locked into our intensive care units for many years, and that had to happen because we were new boys on the block, and we had to build a wall around ourselves in order to establish our specialty. And then, of course, seriously ill people are seriously ill also outside the hospital and also on the streets and with trauma and all sorts of things. So intensivists are specialists in seriously ill people, patients. And we're also leading many of the initiatives. And it's probably good for the most important reason, it's good for patients. At least we're turning up and saying, we have nothing more to offer. You're at the end of the life. Now we're going to try and help you through this process, but it's not really our expertise nor our job. So what do we do next? End-of-life planning is the key. I'm talking about that tomorrow. Many other people are probably talking about the next step, the efferent arm. What do we do next? And finally, I'd just like to ask you for your help on this. We're actually starting to do work on this to try and find out a bit more about it. And one of the things we're doing is, if you could write down that that website up the top and just tell us what your ideas are. So we're doing this survey. We've been doing it for quite some time to get an idea of what doctors and nurses think about all these issues. That's the website up there, and Magnolia's down the bottom there, but probably just go through the website. It's an easy thing where you just tell us what you think about issues. Thank you very much.